what I'm going to do is talk about the recommended sample preparation for both DNA and RNA panels. I really want to talk about, I don't know how many pathologists are here today, but our role in assessing tumour cellularity and the tumour content. I want to highlight some of the challenges, and I just want to finish with just some potential new sample handling approaches that we might be looking at in, in the next months or next year to help us improve our success and expand our ability to do genomic testing. So standard sample preparation. So what I mean by standard is if you want a DNA panel or an RNA panel. As Mike has said, this is optimized for FFPE tissue. Ideally, you'll be fixing your tissue in 10% neutral buffered formalin. And ideally, that will be fixed for less than 48 hours. Now, I know there are some situations like colorectal cancer resections where that is against guidelines. So, this has to be interpreted as a guideline, and we do what we can to optimize the quality. So, a really important part of this is assessing the H&E. I cannot emphasize this more. I mean, it's a cliche, but rubbish in, rubbish out. And I think it's our responsibility to ensure that we send our molecular lab a tissue that is going to give us the best result. So our role on the H&E is to mark up the tumor and to assess it for tumor cellularity and content. Now, you may choose to do this on your diagnostic slide. You may analyze all your slides and then have a fresh H&E cut, whichever. In order to cut the slides for the DNA or RNA panel, you'll be cleaning your blade with methanol. You don't have to change the water bath. You can if you want, but it's not essential. And you're cutting 10 micron unstained sections onto uncharged slides. You need 5 sections for a DNA panel, 5 sections for an RNA panel. Now, of course, any pathologist out there will know immediately that this is hardly an exact science because it depends how big your section is and how much tumor you've got. But this is where your tumor markup becomes really important. So what we really are looking for is enriching the tumor that goes into the test for tumor neoplastic cells. And of course, we all know that the tumor is a mixture of neoplastic cells and microenvironment, and of course, often surrounded by and intermixed with normal tissue. And this, I quite like this cartoon really, because it shows you how the presence of non-neoplastic components within the DNA that goes into these tests will make the analysis of that output very, very difficult, because you have all of that normal DNA being read at the same time. So I think this is a very, very important part of the process. And I really want to emphasize this as something that we as pathologists, in the broadest sense, histopathologists, our biomedical scientists, should be embracing as our role, because we are familiar with looking at H&Es. That's what we do. So to mark up an H&E, I think that sometimes people don't quite understand what they're being asked to do. So we want to avoid areas of necrosis. And what we've got here in this image, and this has obviously been digitally marked up, but this is a lung tumor, and there's a large area of necrosis in the middle. And so the area that has been marked up is actually a viable tumor. It's really important to try and avoid lymphocyte-rich areas, and I'll come back to that. But lymphocytes are small and they tend to be clustered in dense clusters, and they contribute a lot of DNA compared to our neoplastic cells. So they can really drown out the signal from our neoplastic cells. And we want to avoid pigment-rich areas, hemosiderin or melanin. So this is our role. We should be sending a marked up H&E with our unstained sections, and then the lab will use that marked H&E to microdissect where it's necessary. Now, of course, some tumors, and particularly in a biopsy, but sometimes in an excision specimen, you will select a block which is very rich for tumour. The tumour is present throughout the block. Then, of course, you don't need to mark that up because the entire section can go in. So, you just need to assess each case on its merit. We need to give an indication of the total cellularity. This will give information to the lab about what level of DNA or RNA they might be expecting to extract. This may look like, licking your finger and putting it up in the wind, to be honest. And to start with, it sort of is. But actually, if you do this regularly, and I've done it for many years in a research setting, you become quite good at this. And it's I want all non-pathologists now just to switch off the sound, because I want you to retain this idea that we're all very scientific as pathologists, but it's a bit of a best guess here, right? But it's amazing when you do it frequently how reproducible we can become. Tumour content seems to be a lot more problematic. So what we're doing in assessing a tumour content is estimating the percentage of tumour cells in comparison to the non-tumour cells in that marked up region that we're asking the lab to extract from. And so, without wishing to teach grandma to suck eggs, but I have to remind myself frequently when I'm doing this, it's important to remember that the tumour cells are bigger than the normal cells, but the normal cells are still contributing quite a lot of DNA. And as I say, I'll come back to the lymphocytes. You get an awful lot of lymphocytes packed into a small area, and they contribute a lot of DNA. So you need to take that into account. So these are just a couple of examples, and I've taken these actually from the Royal Marsden SOP on assessing tumour content. And this is a non-small cell adenocarcinoma of the lung, and this was assessed as 70% tumour nuclei. So I'm going to illustrate how variable this is right now, because I would have called that 80%. Okay, we wouldn't argue over that. This on the right is a colorectal cancer. Now, this I think is quite interesting, because I agree with this assessment about 30% neoplastic nuclei. It looks as though we have quite a lot of tumour here on the right of that image, but we have quite a lot of normal on the left. And there is a dense cluster of lymphocytes, a band of lymphocytes down the middle. And that is all going to contribute to our non-tumour content. So as Mike said, we are aiming for samples that have at least 20% tumour content. And I do want to say that it is very, very important to really try and be as accurate as you can in giving that tumour content assessment to the laboratory. I also want to say that I think it's important that it is the submitting department, the submitting pathology department, that provides this information, because we are used to looking at our tumour types. We're all very specialised nowadays. I came across a case very recently where a non-pathologist had assessed a tumour as 80% tumour content. When I looked at it, that sort of was true, except that most of that was an in situ component. And actually what we're assessing is the invasive component, and that accounted for 20%. So what I'm saying to you is, you as the submitting pathologist are the best person to do this. So it's really important that we try and provide accurate information so we get the best information back. Of course, the higher the tumour content, the greater the chance there is of detecting a somatic variant, even if it's present at a relatively low frequency. We know that sometimes, we're not in control of tumour content, right? We can macrodissect, which can enhance tumour content, but sometimes there may be tumour content less than 10%. But I think we need to be aware that they may generate false negative results, because the level of the tumour neoplastic DNA is just not sufficient to be sensitive. So this is a very unpopular slide amongst pathologists. I also have issues with it, but there is this generalized statement that pathologists are very poor in their agreement in assessing tumour content. Now, I think that yes, we could be better, but I think sometimes we simply don't understand what we're being asked to do. So, you know, the definition of tumour varies, okay? I mean, in my research world, the tumour very much includes the entire microenvironment. In this genomic world, the tumour is about the neoplastic content. So I think some of this disagreement is about not quite knowing what is required. For that reason, I would very much recommend becoming involved in the Tissue Eye EQA assessment program. So this is a web-based module. It's voluntary at the moment, but it may well become mandatory. It's free of charge. And you basically go in, you log on, and you can go through your own tumour type. And what's great about it is you can benchmark yourself against your peers. And there is absolutely no doubt that we become better when we benchmark ourselves. So I would really strongly recommend that you consider registering for Tissue Eye. And as I say, it covers a range of different tumour types, and that varies through the different runs. And you only have to do, we're all, you know, pretty specialised these days. You only have to do the tumour type that you would, in your real world, actually be involved in assessing. But as I say, I strongly recommend you get involved in this. It is voluntary right now. It's not assessed. It is really about as ourselves benchmarking ourselves, but you know, there may be a move to this becoming mandatory in the future. So I think it would be kind of a smart move to get used to it first. So we have, and it particularly, of course, in the context today of the NTRK testing, been talking about FFPE samples. But of course, another element within the genomic medicine service is whole genome sequencing, and that mandates fresh frozen samples. And this is one of my favorite slides, as everybody knows, which shows all the artifactual alterations that you get induced by formalin fixation. So that's not relevant for us in this particular setting, but I think it does add to our challenges. What are the challenges? Well, Mike has alluded to this, okay? Turnaround times, of course, are incredibly important. In fact, Martin also said something which I totally support. The more that we submit, the more this becomes routine, then the greater the volume within the molecular diagnostics lab, the more runs they will do, the faster the turnaround time. That's an absolute truth. However, I think we also have a responsibility to sort out our pre-analytic pathway, and that lies from the moment the sample is taken, either as a biopsy in the clinic or as a specimen at theatres. Because, you know, let me admit, some of our biopsies can take 48 hours to get to our laboratory. And that's precious time that's lost. And it is possible to change that. And I would be absolutely delighted if there are pathologists on the call here. I'd be really, really pleased to link up with you to talk to you about how we can look at our pathways. There is now a National Genomic Pathology Accelerator Programme. This is some funding through NHS-EI to look at our pathways, to look at where the bottlenecks are. How can we become more efficient? I think the responsibility lies with every one of us involved in the sort of diagnosis and management of our patients to reduce the turnaround time. So we each have our role to play. And we are starting that program. And again, any pathology related people, in fact, anybody who's interested, I would be delighted to talk to you about this. Sample quantity is an issue, as is sample quality. We know that you can only make a sample go so many ways. And, you know, sometimes we have immunohistochemistry to do in order to reach a diagnosis. So you're already diminishing your sample. We're through the Royal College of Pathologists, are in discussion with the Royal College of Physicians and the Royal College of Radiologists, who also are very conscious of this new genomic era. And we're talking about whether there is a place to take genomic specific biopsies. So in other words, maybe the onus isn't entirely on us as pathologists to somehow expand this tissue. Maybe we should be going out to our colleagues and saying, you know, this is important. We need another biopsy. And they're very receptive to that. So this is ongoing. So as Mike has said, he gets excellent results with FFPE. Would non-FFPE give improved results? We don't know. That's something that we might need to look at. But certainly within the context of whole genome sequencing, we're going to have to sort these non-FFPE pathways out. Absolutely. And, you know, whole genome sequencing may seem a world away at the moment, but trust me, it's really, really not. It's going to roll out much more rapidly than any of us ever believed. So what I'm interested in, I think that fresh frozen pathways are onerous. Are there other ways that could generate just as good material for genomic testing that would fit much better with our current pathways? And I'm going to take just a couple of moments, if I may, to flag a little bit of experimental work that we've done. So the first is using an alternative fixative. Now, there are many. We happened to use Paxgene. Paxgene is methanol based. It comes in this rather natty little container, which, apart from the label on the front, looks exactly like formalin and can be sent out and sitting on clinic shelves for many weeks. Okay, it is very stable. And what we did was to go directly to compare fresh frozen tissue, which is the second bar in this group, with Paxgene prepared with a PCR-free preparation, which is the dark purple. And I'm conscious of time, so I don't want to spend too much time here. I'm just going to point out to you that formalin fixation, one of its artifacts is a drop in AT coverage and overrepresentation of GC-rich regions. What we see with Paxgene PCR-free preps is it very much mirrors fresh frozen tissue. So that was really encouraging. And then I'm just going to show you this, which is a profile, a whole genome sequencing profile here at the top of a fresh frozen sample, and underneath its partner Paxgene prepped PCR-free DNA, and they look virtually identical. If you look at the bottom panel, you look at the effect of FFPE, and I hope you can understand why Illumina have refused to take FFPE for whole genome sequencing. It's just, you know, it's really difficult to interpret. So Paxgene looks pretty good. We don't know whether it would improve any success rate on our DNA panels or RNA panels, but that's something for Mike and I to pick up on and feed back to you lot. And then finally, I just want to mention something called the shaken biopsy. This was the brainchild of a cytopathologist, where we took a biopsy, we put it into sterile PBS, and we shook it for 60 seconds. We took the biopsy out, stuck it into formalin, and sent it off for routine analysis. We then spun down what we'd got in the PBS, and we looked at the DNA. We actually sent this for sequencing. And we did a couple of permutations on this. I don't want to spend too much time, but I was trying to recapitulate a clinic situation. So could we leave those that PBS with those cells in it for 12 hours? Could we leave it for 72 hours and still get really good DNA out of it? And in a nutshell, what I want to show you, and I'm not going to go into any detail because of time, but the dark bar is the cells from the shaken biopsy. The paler pink bar is the fresh frozen tissue. And what you see here is that we get higher tumor purity in the shaken biopsy. That won't surprise many of you. It's the tumor cells that shake off because they are less cohesive. We have a higher mutational burden from our shaken biopsy than the fresh frozen. Well, maybe that's because we've got more tumor cells present. And what we see is a very good overlap between the fresh frozen sample and that shaken biopsy, although we have a higher SNV count from the shaken biopsy. Again, probably because we have an enrichment of tumour cells present. So in summary, I think the key things to take home is that accurate tumour assessment and markup of those samples is really, really important. We need to send the molecular diagnostic lab the material that they need to give us a good result. It's really important to submit that marked up slide. And I would advise any person involved in assessing the tumour to register for Tissue Eye. So you've seen that the DNA and the RNA panels work on FFPE, which is brilliant. Would they improve performance on non-FFPE? We don't know, but we'll get back to you. We're going to have to get used to non-FFPE tissue because whole genome sequencing will increase. So we need to find better ways of doing this, which will be less onerous on everybody. And I think I'll probably just finish there with a final thing to say that there's a great online program about tumour assessment, which I am just going to paste into the chat right now, I hope. And the only other thing to say is, you know, if anybody wants to pick up on any of this, I'd be absolutely delighted to talk to you. Thank you.